You're listening to the recorded lecture for management of patients with kidney disorders. By the end of this chapter, you should be able to describe the key factors associated with the development of kidney disorders, differentiate between the causes of chronic kidney disease and acute kidney injury, explain the pathophysiology, clinical manifestations, medical management, and nursing management for patients with kidney disorders. Understand the nursing management of patients with chronic kidney disease as well as acute kidney injury. Compare and contrast the renal replacement therapies, including hemodialysis, peritoneal dialysis, continuous renal replacement therapy, and kidney transplantation. And develop a post-op plan of nursing care for a patient undergoing kidney surgery and transplantation. Kidney disorders often lead to fluid and electrolyte imbalances. So you need to have strict intake and output monitoring as well as daily weights so you can see if there is any fluid volume overload or deficit. Chronic kidney disease refers to kidney damage or decreased in the GFR lasting 3 or more months. Untreated chronic kidney disease can lead to end-stage kidney disease, which is meaning the kidneys just aren't functioning anymore. And at this point, the patient will require renal replacement therapy, dialysis, or a kidney transplant. The kidneys are susceptible to adverse effects of medications because they're repeatedly exposed to the substances in the blood, and this can cause damage as well. Patients with CKD or chronic kidney disease are at increased risk for cardiovascular disease. There are different stages of CKD. There are 5 stages. In stage 1, there is kidney damage, but if you check the GFR, it will be normal. Stage 2, you have a mild decrease, and the actual numbers are in the book. But stage 2, there's a mild decrease in GFR. 3 is moderate decrease. 4 is severe decrease. And then stage 5, you have end-stage kidney disease, and you have less than 15% glomerular filtration, and that is not sufficient to sustain the kidney function and remove those toxins from the blood. As serum creatinine levels rise, symptoms of CKD will begin. So initially, there really aren't any symptoms. As the creatinine levels rise, though, you will see anemia, metabolic acidosis, as well as abnormal calcium and phosphorus levels, and the calcium will generally decrease as the phosphorus increases. And if you remember back to fluid and electrolytes, if calcium is low, phosphorus will be high, and then if calcium is high, phosphorus will be low. Fluid retention, edema, electrolyte imbalances will all worsen. Hypertension will become harder to control as well as CKD progresses. As far as treatment, treat the underlying cause. So what is causing the chronic kidney disease? See if you can treat that cause. Renal replacement therapies, if you're at end stage, you have to do the renal replacement to get the toxins out of the body. And then you want to prevent complications as much as possible. If your patient is a smoker, they need to stop smoking. If they are obese, they need to lose weight. Get them on exercise programs, and that will help with circulation, that will help with the heart health and blood pressure. And then if they are abusing alcohol, they need to reduce or completely stop drinking. And they need to follow a low sodium diet, generally low phosphorus as well. Nephrosclerosis can be malignant, which means it's accelerated, or it can be benign. It has decreased blood flow because of the hardening of the renal arteries, and this will cause damage to the renal parenchyma, and then this leads to fibrosis and destruction of the glomeruli. And with the destruction of the glomeruli, you're not able to filter out the toxins. There's really no signs and symptoms early in the disease. However, if you do a urine test, you can see protein. Sometimes you'll see casts as well. Treatment, aggressive antihypertensive therapy to keep the blood pressure under control, and that will help to control the pressures of the renal arteries. You can give ACE inhibitors, and you can give them with other antihypertensives or you can give them alone. Glomerular diseases. Acute or primary glomerular disease is the third most common cause of stage 5 or end-stage renal disease. The antigen-antibody complexes will form in the blood, and they'll travel and become trapped in the glomerular capillaries. This will induce an inflammatory response, and then the inflammatory response will negatively affect the glomeruli. Primary glomerular inflammation, the patient will present with hematuria, so blood in their urine. They will also have edema and azotemia, or abnormal concentration of nitrogen waste in the body. They will also have proteinuria, which is excessive protein in the urine. Primary presenting feature of acute glomerular nephritis or acute nephrotic syndrome is the hematuria. This might be visible by the eye. It also might be microscopic. Complications include hypertensive encephalopathy, heart failure, and pulmonary edema. And that's just because generally fluid overload. As far as nutrition goes, you are going to encourage carbs for energy and limit proteins because they have too much protein anyway, and their body isn't able to process the waste from breaking down the proteins. Proteinuria, microscopic hematuria can persist for months, and that does need to be monitored. The patient will be on strict intake and output so that you can see how the kidneys are functioning. You'll get daily weights. The patient needs education on the management of symptoms as well as monitoring for complications. They will be put on fluid restrictions most likely, so they need to be aware of what that means. They need to do daily weights, and when they're doing daily weights at home, it needs to be the same time every day with the same amount of clothes. So what I usually tell my patients is, get up in the morning, go to the bathroom, take all your clothes off, weigh yourself, and then get ready for the day, and then monitor that weight. They also need to watch for nausea, vomiting, fatigue, diminished urine output, blood pressure monitoring. They need to do their follow-up visits so that they can have their urine monitored, and they'll also probably want to get electrolytes as well as kidney function tests done routinely. They'll also monitor their blood pressure, and they can do that at home as well. Chronic glomerulonephritis is caused by repeated episodes of kidney injury, and the repeated episodes of injury will eventually lead to scarring and formation of fibrous tissue. Because of the formation of the fibrous tissue, the kidneys shrink and they become ineffective in filtering out the toxins and the fluid like they need to. Signs and symptoms do not show up until later in the disease process. They include weight loss, increased irritability, loss of muscle strength, nocturia, which means they're getting up at night to go to the bathroom, headaches, dizziness, and then digestive disturbances, which in chapter 53 we talked about how if you have renal dysfunction, you have digestive symptoms as well. Management is determined by the symptoms and the causes. As far as the urinalysis nursing process, you're going to do an assessment. You're going to get a history of the present illness, patient history, any previous incidents of kidney issues, GU issues. You will most likely get a urinalysis. The specific gravity will be checked. You're going to check for protein in the urine, urinary casts, and then you're going to check for later stage CKD symptoms. So you'll get the glomerular filtration rate. You're going to make sure that their electrolytes are good because later stage CKD patients have hyperkalemia. They can have metabolic acidosis, which is checked by ABGs. They can be anemic because of the decreased erythropoietin production because of the kidneys being damaged. They'll also have increased serum phosphorus and decreased serum calcium. They can have mental status changes and enlarged heart and pulmonary edema. So you're going to want to monitor neurologic status, cardiac status, provide emotional support to the patient and their family member, and then educate them in self-care. if it's chronic, it's something that they're going to have to learn how to manage. Nephrotic syndrome is manifested by massive amounts of protein in the urine, decrease in albumin in the blood, diffuse edema, high serum cholesterol, and low density lipoproteins. The major clinical manifestation of nephrotic syndrome is soft pitting edema, and you'll see it periorbital, so around the eyes, and then any dependent area. So the sacral area, the feet, the ankles, the legs, depending on how bad the edema is. Patient can also have ascites, which is excess fluid in the peritoneal cavity. They can also present with a headache, irritability, and malaise if they have CNS symptoms. Treatment is addressing the cause. You want to do what you need to help slow the progression of chronic kidney disease, relieve any symptoms that they might have. They can be placed on diuretics to help get rid of the excess fluid that is causing the edema, or because of the edema. They'll be put on an ACE inhibitor, and then if they do have the higher cholesterol, they'll be put on lipid-lowering agents as well. They will also be on dietary restrictions as far as fluid intake, and then phosphorus. Excuse me, and potassium if their potassium's high. Polycystic kidney disease is a genetic disorder. It can be autosomal dominant or recessive, but it's most commonly dominant, and I believe it's at 90% of the PKD cases are autosomal dominant. Your patient, what happens is their body will start to produce multiple fluid-filled cysts. They will form in the kidneys, and the formation and pressure will destroy the nephrons. They can also form in the liver, blood vessels, brain, and heart. And so this will cause obstructions in the blood vessels, damage to the liver, and the liver isn't able to metabolize like it used to. It can cause issues with brain function. So you'll see neurological deficits, and then you can see heart issues, dysrhythmias, because of the cysts in the heart. Signs and symptoms: your patient will present with hematuria, polyuria, hypertension. Renal calculi is not uncommon. They'll have frequent UTIs, and they'll have proteinuria. There is no cure for polycystic kidney disease. It's mostly supportive and palliative, so keep them comfortable and do what you need to based on symptoms. And so you can call the physician, work collaboratively to help those patients be as comfortable as possible. Acute kidney injury. This is rapid loss of renal function, and generally it's due to damage to the kidneys, and it can be from trauma. It can be from hypovolemia or hypotension that is acute and rapid on onset. Reduced cardiac output and heart failure. It's seen a lot with shock, and so secondary to a patient who's in some form of shock. Can also be caused from obstruction, whether it is obstruction somewhere in the kidney or the renal arteries or veins are actually obstructed, which decreases perfusion. There are 4 phases of acute kidney injury. The first phase is the initiation period, and that begins with the initial insult, and then it ends whenever oliguria develops. Phase 2 is when oliguria starts, and that's the oliguric period, and it is accompanied with increased serum concentration of substances that are usually excreted by the kidneys, hyperkalemia, and it can last 10 to 14 days. Phase 3 is the diuresis period, and so you have gradual increase of urine output because glomerular filtration is starting to recover and the nephrons are starting to work again. And then in phase 4, the recover period, this is when you have improvement of renal function. This can take up to 12 months, so anywhere from 3 to 12 months for the recovery period. Signs and symptoms of acute kidney injury. Your patient can present with dry mucous membranes, headache, drowsiness, muscle twitching, seizures, and if they can show up critical, they can be in hypovolemic shock and have those symptoms as well. As far as what the nurse does to help these patients, electrolytes are monitored, BUN, creatinine are monitored, strict intake and output. ABGs will be done to make sure metabolic acidosis is not an issue that needs to be addressed. The patient will be on a high carb diet, restriction of potassium and phosphorus. So banana, citrus fruits, the citrus juices like orange juice, grapefruit juice, pineapple juice, those sorts of things. Coffee will also be restricted. And then once the patient hits the recovery phase, they'll be able to go to a high calorie, high protein diet. But they really want to limit the protein and just have a high carb diet whenever they have the acute stages. Hyperkalemia, I already said, is an issue, and this affects the heart, and you can have a dysrhythmia or even an MI and go into cardiac arrest, so that's a big deal. Pericarditis, pericardial effusion can happen, and that's because they have oliguria and the fluid is actually being displaced. Hypertension is caused by sodium and water retention. The renin, angiotensin, aldosterone system is malfunctioning, and so you're not getting the diuresis that you need. The ADH hormone is not doing what it needs to do. And then anemia is because of the decrease in epopoietin and bone disease and metastatic calcifications. That's because of the retention of phosphorus. And then you have the low serum calcium levels, so you can have the brittle bones because the calcium isn't able to keep the bone density up. Abnormal vitamin D metabolism, as well as elevated albumin levels, can all affect the bones. Goals: you want to maintain your patient's body weight, and so you'll do daily weights, intake and output. Make sure they're getting adequate nutritional intake following their restrictions. They need a lot of education about what's going on, especially with acute kidney injury, and why it is so important that they follow their restrictions. They need to be up and active as they can tolerate so that you can get the circulation going and you can stop any other complications like a DVT or atelectasis or pneumonia just from lack of movement. Improve self-esteem. If they have a lot of edema and swelling, then they are not going to look like they normally do. Sorry, excuse me. They are not going to be as active and mobile. Their endurance is going to be down. So look at the patient holistically. And then obviously you want to monitor for complications and prevent complications as much as possible. My goodness, excuse me. I have to sneeze again. You want to monitor for excess fluid volume. Again, I&O, daily weights. Look at their edema, so look at their whole body, especially if they're in bed, their sacral area. Look at their abdomen for ascites. Limit fluid to whatever the physician has decided the fluid restriction needs to be. And then make sure you're looking at all types of fluids, especially if they are getting IV therapy. Patients generally don't like to be on fluid restrictions because it is significantly less fluid than what they are used to. And so sometimes instead of giving them water to drink, you can give them ice chips or a popsicle, and that'll help to keep the mouth moist without them actually consuming as much in the way of volume of fluid. And good oral hygiene is also imperative because they're not able to drink as much as they used to. They can suck on lemon lozenges, and that'll help produce saliva and keep the oral mucus membrane moist as well. Make sure that they're getting enough vitamins, minerals following their restrictions. They're getting plenty of carbs because they are going to be burning through a lot of energy. Low self-esteem, I already talked about that. Renal replacement therapy. So we are going to focus mostly on hemodialysis and peritoneal dialysis because those are the two most common types that you'll see. Hemodialysis occurs every 3 times a week. Each treatment can last 3 to 5 hours. It can be outpatient or inpatient. It can also be done in the home. And toxins and waste are removed from the bloodstream by diffusion as the blood passes through the dialyzer, and because the concentration of the dialysate is lower than that of the blood. And so it pulls the substances away and out of the bloodstream into the dialysate. So those toxins and other substances are being pulled into the dialysate, which is then discarded. Excess fluid is removed from the bloodstream through osmosis as well as ultrafiltration. And there's different types of vascular access in order to get hemodialysis. So this is one type of access. The arterial blood. Let me get my little pen here. And I'll make it a different color since that's red. So the arterial blood is going to come out and through the dialyzer and the fluid. And then it's going to, there's a filtration system here so that you don't get any bubbles or clots that are introduced back into the bloodstream, and it goes back up into the venous system. And then this is right here. The fluid goes in, blood comes through. I lost my little, where'd it go? There it is. Blood comes in. This is the filtration system that has the dialysate that is being pumped in and then pushed back out as the blood's going down. And that's how the blood gets clean. Really cool if you can see it done. Acute care, so they need immediate dialysis and it's going to be short term. They can put the catheter here. They can also insert it here if they can't insert it centrally on the chest. But there is a cuff that's inflated and it's kept in place. And then there's a red and a blue. Red and one's in and one's out. If they have one of these for dialysis, they are only used for dialysis. So only used for hemodialysis. You can't use it for IV fluids. You can't use it for antibiotics. If the doctor wants antibiotics during or after hemodialysis using that port, it has to be done by the hemodialysis nurse. Cannot be done by the floor nurse. Another way for longer term hemodialysis is through an AV fistula or graft. The arteriovenous fistula, called an AV fistula, is the preferred method for permanent vascular access. And what they do is they take the artery and the vein and they join them. So right here, they join them down in the forearm. They wait for it to mature, and then they will have a needle inserted into the artery and the vein, and the fluid or the blood will come out into the dialyzer through the artery, and then when it's all clean, go back up through the cephalic vein. An AV graft is the same idea, but it uses a graft. It can be biologic material, semi-biologic, or completely synthetic. And it's put in between the artery and the vein to join the artery and the vein. The problem with these grafts is that they tend to clot and have infection more than just doing the AV fistula. When you have a fistula, it's really, really neat if you have a patient that on the floor that has one and you're in clinical, whether they're your patient that you're caring for or not. See if you can go up and check out their fistula, because they should have bruit and thrill. So you should be able to hear this whooshing sound, and whenever you touch it, it feels like a vibration. Totally cool. And most of the people who are on dialysis, they're like, sure, feel my arm. And they'll tell you everything and anything you ever wanted to know. Dialysis patients are usually pretty good about, if you want to talk about their treatment, they're pretty open with you, very well educated. An alternative to hemodialysis is peritoneal dialysis. And this is where sterile dextrose dialysate is actually infused into the peritoneal cavity through an abdominal catheter. The abdominal catheter is placed by a physician, and it can be done in the OR, it can be done in interventional radiology, and then it's sutured in place. And it has an occlusive cover dressing whenever it's not being used, and then you would remove the dressing, drain the fluid, infuse the fluid, and then cap and cover it back up. It still uses diffusion and osmosis to remove waste products and fluid, as well as ultrafiltration. The ultrafiltration for peritoneal dialysis is done by having the higher glucose concentration in the dialysate than in the bloodstream, and that will help to pull that fluid out. It can be done in the hospital, in the home. It can be done by the patient, or the patient might initially need to have a nurse come in and do it. Whenever that catheter, abdominal catheter, is exposed and you're doing this kind of treatment, they should have a mask on. So he should be wearing a mask. And you shouldn't have any moving air. So the window should be closed, the fan should be off, because you don't want anything to get here and then have them get an infection and get peritonitis. Okay. Before you start therapy, you would obtain baseline vital signs. The patient weight is done. Their electrolyte levels are always monitored whenever they're on dialysis. And then if there are any medications like insulin or any kind of electrolyte that needs to be put in there, if you need to add heparin, then that can be added prior. And that's added right here. Here's your little infusion port. And you'll have, this is the dialysate that needs to go in, and then this is the dialysate that's drained. So what you will do is there should be clamps, and you open the clamp to drain from the abdomen down here. So there's a place where it will drain, and then you can clamp this off and drain the new stuff in, and then it can sit and do what it needs to do. One exchange, so they call them exchanges, and one exchange includes infusion of the fluid into the cavity, the dwell time, and then the drainage of the dialysate. The infusion usually only takes about 5 to 10 minutes, and then drainage takes about 10 to 20 minutes, so it does take a little bit longer. You do need to look at the drainage. Well, the dialysate that's going in needs to be clear, and you need to make sure it's clear before it goes in. Otherwise, you're introducing something into the peritoneal cavity that's not a good idea. And then the drainage that comes out should be colorless. It might be straw colored. It will be odorless. You shouldn't have any odor. You also shouldn't have any drainage coming around the tube, and the insertion site of the tube should not have redness, inflammation, anything like that. If you notice that the dialysate that's coming out is cloudy, that's an early symptom of peritonitis. You need to let the physician know right away. Peritonitis is the most common complication of peritoneal dialysis. It is also a serious complication because you're putting all that fluid into the peritoneal cavity. So if there is an infection that's in there, it can hit a lot of different organs and cause severe organ damage. If you have a patient on dialysis, make sure that you protect the access. Make sure you monitor the access for signs of an infection. If they have an AV graft or shunt, you don't do any type of blood pressures or blood draws in that arm, and you do not access that arm that's only for dialysis. You are going to do INO, you're going to do weights before and after dialysis. You're going to check their urine labs and their serum labs, whatever the physician ordered. You need to not only look at the numbers, but you need to look at the trending of the numbers, especially with the electrolytes and the kidney function, to see if it's better or worse, because most likely they will be abnormal just in and of themselves because they have end-stage kidney disease. You're going to monitor cardiac and respiratory status because they could have metabolic acidosis, and that would show up in the respiratory status, and then their electrolyte imbalance can cause cardiac anomalies. Cardiac medication should be held prior to dialysis. Patients who get dialysis generally become hypotensive. And then also, if you think about it, you're taking everything that's in their bloodstream, and then you're filtering it through a machine that removes all of the toxins and anything in the bloodstream, cleans the bloodstream, and then puts it back in. So they might not, most likely they're not going to be getting the benefit of the medication anyway. And you can contact the pharmacy and the physician if you're not sure what they can and can't take, as well as, if they can get something, if their dialysis isn't until 1 or 2 in the afternoon, should they get their 8 a.m. meds? Those are things that you need to discuss with the physician and work with the physician on. You are going to restrict dietary protein because that will decrease the nitrogen in the bloodstream. It can reduce uremic symptoms. It can also postpone the initiation of dialysis if that's something that they're looking towards, if they have chronic kidney disease. You want to do fluid restrictions. They're always going to be on fluid restrictions, and the fluid restrictions can change based on what their labs come back and the signs and symptoms that they're showing. Sodium is going to be restricted as well, and then potassium is limited, as well as phosphorus. As for kidney surgery, pre-op, you want to make sure that they get an adequate amount of fluids, that they're well hydrated, especially if they're going to have kidney surgery, because the surgery in and of itself can cause temporary inflammation. So make sure that they're well hydrated, that the kidneys are flushed and ready to go. They will get antibiotics prior to surgery. You'll get a good health history. Make sure that they don't have any allergies. You'll do coag studies to make sure that their platelets are good and that their bleeding times are fine before they have surgery. Obviously, you don't want them to bleed out on the table. During the surgery, patient positioning, they have to be able to be put in different positions, and you might have to help with that if you're in the OR. And then they have to determine how they're going to manage urinary drainage. So they might need to have some sort of temporary drainage device or permanent, like a nephrostomy tube or a urostomy, based on what kind of kidney surgery they're having. Post-op, manage and monitor for potential infection or thrombus. Make sure they don't get a paralytic ileus. They can have swelling because of where you're going in the kidney, so they can have abdominal swelling, but it shouldn't be too severe. It can show signs of internal hemorrhage if they have a lot of abdominal distension. And then signs and symptoms of shock are also something that you need to watch for. You're going to monitor their pain and make sure you provide good pain control, intake and output. They're probably still going to be on daily weights, and then frequent vital signs. You're also going to be looking at the site. So there's different incisions and different positions that your patient will be in. The physician will determine which position they want the patient to be in. But they have to be able to be in those positions in order to have that surgery. If they have a kidney transplant, this is what it looks like. So the diseased kidney is going to stay. So this is your diseased kidney. They do not generally remove that. It stays where it's at, and the new kidney is put down here, more in the pelvic cavity. And then the good kidney, if they have a good kidney, or the one that they're not working on, stays here. But all they do is take the ureter that was here and replace it and move it to attach to the new kidney down there. Pretty cool. But they have one non-functioning and then 2 good kidneys. When you do an assessment, make sure you assess all body symptoms because the patient can have complications. So don't just focus on the urinary system. They can have GI symptoms post-op if they do have inflammation of the kidney. And you also have a chance of electrolyte imbalance and enlarged heart or pulmonary edema just because of the type of surgery and the organs that are being worked on. You'll maintain good electrolyte monitoring, so they'll get labs frequently. And then you need to make sure that the urinary drainage system is patent and it's draining sufficiently adequate amounts. And that's part of your intake and output. Pain relief measures, they might come off with a PCA immediately post-op. So you need to make sure that they understand how to use that, and then as they're being taken off of it and put on other medications, why you're doing it and how it will help and the difference between the medications, because patients do not like being in pain. And when you take away that PCA pump, they get really anxious, but they just don't understand that the medications in the PCA pump are very short term. They have a short half-life. And if they can get pain control with opioid analgesics, those actually last longer and they'll get better pain control. They need to use an incentive spirometer. They need a tough cough, turn, and deep breathe. They need to splint that area because that will help with the pain. You might need to assist them in positioning because they are going to have pain from the surgical site and muscle pain. And then the pulling whenever they try and turn and reposition will be uncomfortable as well. That all drainage systems need to be patent, and if you notice decreased or no output out of one of the systems, you need to notify the physician right away because that could mean that there's a blockage. If they have an indwelling catheter, make sure that you maintain strict asepsis, that you clean around it every shift, and that the bag is lower than the bladder so that they don't get any type of reflux and they don't have any urinary stasis because that can cause infection. You do want to get them up and out of bed just like any other surgery. That's not any different. Make sure that they are moving, doing their ankle pumps and moving their legs. Get that circulation going so that they don't get any kind of blood clot. Okay. And then you're going to educate them. If they go home and they still have a drainage system, they need to know the type of care. They're going to clean the site daily. If there's a dressing that needs to be changed, they need to know the signs and symptoms, what to look for, ways to prevent complications like pneumonia and atelectasis and blood clots and infection, signs and symptoms early on that they need to report to the physician, importance of fluid intake to flush the kidneys and get them up and working again, as well as signs and symptoms of fluid retention. And then they need to have good follow-up care. And if they're on antibiotics afterwards, they need to take all of their antibiotics. They should be monitoring how much they take in and how much they are eliminating so that they can make sure that the kidneys are functioning well.